Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. Today's episode features content from an educational program titled Contemporary Management of HIV, Integrating New Data from IAS 2021. During this podcast, Dr. Eric Daar, Chief, Division of HIV Medicine at Harbor UCLA Medical Center and Professor of Medicine at David Geffen School of Medicine at UCLA in Los Angeles, and Dr. Shobha Swaminathan, Associate Professor, Division of Infectious Diseases, Department of Medicine at Rutgers, New Jersey Medical School, discuss key data from the IAS 2021 conference. For more information about Dr. Daar and Dr. Swaminathan, and for a link to the full online educational program, including downloadable slides specific to today's podcast, please visit the link in the show notes for today's episode. Now, let's get started and hear what Drs. Daar and Swaminathan have to say about key data from the IAS 2021 conference.
So let's go to some novel new therapeutics that have just emerged and looking at the role of long-acting cabotegravir plus rilpivirine for treatment-naive persons with HIV. So the FLAIR study, and these are 124-week data, we're looking at AR treatment-naive adults who had a viral load greater than 1,000 copies per mil, Hep B negative, any CD4 count, but they couldn't have any NNRTI or RAMS because they were on a two-drug regimen with rilpivirine. And they initially had an induction phase with a traditional three-drug regimen using dolutegravir, abacavir, and 3TC. Once they were suppressed, they were then randomized to oral CAB plus rilpivirine for 4 weeks. And the oral lead-in is really to ensure tolerability of the drug, and I didn't look for any hypersensitivity reaction that might occur. Before they got switched to long-acting cabotegravir, 400 milligrams, or rilpivirine long-acting, and these were 2 injections given every 4 weeks, and the other half were continued on the oral regimen of dolutegravir, abacavir, 3TC. And these participants were followed for up to 96 weeks. At 96 weeks, the group that was on the oral 3-drug regimen, they had the option to either get switched to the CAB rilpivirine oral followed by the injectable or direct injectable. This current analysis is looking at this top right square, looking at week 124 data on the group of participants who were originally randomized directly to the injectable drug. So what are the virologic snapshot outcomes with long-acting CAB plus rilpivirine? There were 229 participants in this data set. And since the week 96 analysis, there were 5 additional participants who had an HIV RNA greater than 50 copies per mil, and 1 additional person who had confirmed virologic failure. There were about 13 participants who were not recorded as suppressed, predominantly due to non-virologic reasons. They moved or no virologic data, etc. So when you look at the graph on the right, looking at virologic outcomes, the primary endpoint of virologic non-response was 4.9%, so a very small proportion of patients did not respond as expected. 80%, the secondary endpoint, met the virologic success with viral load less than 50 copies per mil, and about 15% had no virologic data available. So clearly the switch was highly effective and met the endpoint for maintaining efficacy. So then let's look at safety and tolerability, because that remains the primary concern when switching to injections. The first reaction I see from patients is, wow, I'm going to get an injection. So let's look at the safety profile to see really what the study showed, right? So yes, as expected, predominantly the arm on the injection did have significantly more number of adverse events reported. That being said, the majority of the adverse events were fairly mild, grade 1 or 2. When you look at grade 3 or 4 AE in the CAB rilpivirine arm, it was only about 13% and about 3% on the comparator arm. And when you look at the drug-related adverse events, they were, pyrexia, fever, headache, and fatigue were the most commonly reported side effects. But when you look at the adverse events that ultimately led to withdrawal of the study product, was in a very small proportion of participants, just 5%. There were no drug-related serious adverse events, and there were no adverse events. So in general, the take-home message from this is that in general, it was quite well tolerated with predominantly mild to moderate side effects, with non-injection side adverse events being headache, fatigue, and some maybe fever. as expected, injection site reactions were the most common adverse events reported. So there were about 283 participants, but as you can see, there was 17,000 plus injections administered on the study. Of those, ISR stands for injection site reactions, was just over 3,000, with the most common being pain. 18% of the injection visits had pain. But when you look at more significant adverse events, such as nodules or in duration, they were very small. Less than 1% of all injections actually had those slightly more significant, with the mean duration of injection site reaction about 3 days. But how many of these injection site reactions ultimately led to discontinuation of the medication? There were a total of 7 participants, or 2%. So I think the injection site reactions, yes, they are expected. I tell my patients, yes, it's an injection, you might have some soreness, but for the most part, most people, it gets better in a day or two, and it's generally mild and well tolerated, is what I tell. So that's with respect to the safety and tolerability. Now, when you look at additional confirmed virologic patients, so there was one participant who actually failed with emergence of resistance. So this was a male participant with a BMI of 24.7. So, not overweight, ideal body weight. His HIV-1 subtype was A6. And this is important to note because even though we don't routinely measure this data clinically, A6 in other capital-equivalent studies has been associated with a slightly increased risk of virologic failure. There were no baseline resistance mutations, associated mutations detected. And the viral load suspected at confirmed virologic failure was 887 and then subsequently went on. Now, when you looked at the type of mutations that emerged, as you can see, there were some classic rilpivirine-associated mutations that developed, including INSTI-based resistance. So clearly, this participant failed with development of resistance to both drugs on the regimen. So then you look at the week 8 troughs to see, and the week 8 troughs in other studies, were associated with people with low week 8 troughs who more likely to fail. So when you look at the week 8 trough, the CAB level was 1.05 and the rilpivirine was 24. So where does that compare with what's expected? So when you look at the footnote below, yes, it was slightly on the lower side because the median week 8 trough for CAB was about 1.56, but it still wasn't terrible because the range of that was 0.5 to 3.6. It was low-ish, maybe like at the 25th percentile, but not terribly low. And similar for rilpivirine, the trough here was 24.6, slightly lower than the mean of 41, but well within the acceptable range of about 18 to 92. So it's still, and interestingly, he did resuppress on a simple 3-drug regimen with efavirenz, TDF, FTC. So I'm glad that the participant ultimately did well. But this does raise other issues or things about what we should be thinking when trying to identify the appropriate patient to switch to rilpivirine. So I don't know, Eric, if you want to weigh in about the type of patient that you have or are considering switching to rilpivirine?
As you said, the tolerability is actually really good. When you look at the data and you look at injection site reactions, yeah, there are lots of them, but you'd expect that. But, the truth is the majority of people who go into these trials, at least, really liked it and wanted to stay on it. And if they had those injection site reactions, they generally got better over a few days and got better over time. So I think the key, what we learned from the trials, at least for now, is the appropriate people for this treatment are the people who really want it, because that's the group that were enrolled in the trials. I'm not sure we're in a position to be encouraging people for something that they don't want, because it is a bit of a burden. No burden of daily pills, that's great, but a new burden of, at least for now, every 4 weeks, 2 injections. And hopefully soon we'll have approval of every 8 weeks, which would be amazing. People have to only think about their treatment 6 days a year, which would be extraordinary. So I think it's for people who really want it. And then the other big issue is the adherence. These studies pre-selected for people who were stably suppressed, and as most clinical trials and switch studies, were highly adherent to therapy. And we're committed to coming back and getting injections on a regular basis. We don't know about people who are not as committed. to either taking their medications daily or showing up for their clinic appointments. And, that's the group I think I worry the most about because, right, that if they don't come in and get their injections, they're going to have eventually low drug levels. At some point, they may have higher levels of one drug, like the rilpivirine, than the cabotegravir. And, we used to talk about functional monotherapy when people stopped efavirenz-based therapy, and that was for a few weeks. This could be functional monotherapy for months. So I still think we need to be really careful with that group. There is a study going on through the ACTG looking at poorly adherent patients. So I think we need that kind of data before we extend this to other groups. So for me, that's the main thing right now. Do they want it? And are they committed to coming back and getting injections on a regular basis? It's really interesting, the data with subtypes, whether we should be thinking about predictors of poor response. And there have been several studies that have suggested that certainly this A6A1 subtype, which is almost exclusively found, as far as I know, in Russia, so maybe a little bit less of an issue for us, except for some immigrant populations. It's more common amongst those who experience virologic failure, but there are several studies that suggest that it alone isn't enough to be a high risk for failure. It was really in combination with high BMI, which correlates with the drug levels that you were referring to, and underlying resistance to rilpivirine. If somebody's failed NNRTIs in the past, we need to be extremely aware of. If they haven't, we don't routinely look for that, like with archived assays. Although I think it's interesting, I think at some point we may think more and more about it. Right now, I mostly am focusing on the patient and not these other unique characteristics that might put them at higher risk for failure. What's your experience since the approval? Have you rolled it out in your clinic yet, or is it something you're working on?
So we have a process in place, and I think we sent our first prescription and waiting for it. So there's a two-step process in the rollout. The first is getting approval for the oral drug, which is managed by the company, has a special prior authorization. And the second piece is trying to get in place a process to get the injections, because you do want to get them in a timely manner. And, I work in Newark, New Jersey. We have a lot of patients who have unstable housing or who don't feel safe getting their medication shipped to the house. So we actually developed a system where our hospital was kind enough to work with us. So the medications will get shipped to the hospital pharmacy and be stored there with their name. And the day the person comes into our clinic, then our staff goes and bring their medication. Because as you know, the meds have to be stored at a certain temperature. And once they are out, the vial can be at room temperature for X number of hours. But syringe to skin time is about 2 hours. So we really don't want to puncture the vial until the person has arrived in the clinic, because we don't want to waste the medication. That being said, I have been surprised because I have some patients who are suppressed. Of course, it's a mix, but some who really are tired of taking the pills, because for some of them, they feel, oh, this reminds me. And every time I see this pill, it's a constant reminder that I still have HIV. So for them, if they are committed to coming in every month, which, as you said, can be burdensome, for them, they're fine. So we have dedicated like a day, like a CAP Thursday, because that's our late day. So for working people, they can come. And that's how we roll it out. Now, if we need to expand, we will do others. But as you mentioned, I think for those who are unsuppressed, finding the right person, like adherent enough to come to clinic, but not adherent enough to take their meds. I think for those, something like the Latitude study that the ACTG is doing would be a good way to see if we can actually help address the other 50 to 20% that are still not, virally suppressed, or definitely not consistently suppressed, to see if this would meet their needs.
The other group that I thought was interesting, and there was another study that might be somewhat informative, was, I'd be very careful using this in somebody who's experienced failure on an NNRTI in the past. But there are a bunch of these people in our clinic that we do baseline resistance and have transmitted K103N. And we know that, people who acquire NNRTI resistance can have 103N plus or minus other mutations. Transmitted, usually if that's what they have, that's what they have. And we know rilpivirine is active if you just have K103N. And there was a study presented at IAS, not with long-acting CAB rilpivirine, but with dolutegravir rilpivirine in people with archived 103N who had no history of virologic failure. So presumably these were all people who had transmitted resistance, and they switched them to dolutegravir rilpivirine. oral agent and had very high rates of viral suppression. So I think that data may inform this for that select group that really wants this, but happened to have acquired 103N at the time of their infection.
Right, and I would add caution with use of archived genotype, because archived genotype can frequently miss prevalent mutations up to 50% of times. I mean, if you find mutations, it's helpful, but I don't know that a negative or lack of detectable mutations in the archive necessarily rules out presence of mutations in the virus, because it's a sampling factor.
Yeah, I totally agree. And that's how some of these analyses that looked for baseline rilpivirine resistance used the archive. But you're right, it was if you detected it. If you don't detect it, you really don't know. So let's move on to the next part of the presentations. And we're going to start by talking about a pretty exciting new drug in a new class that's moving forward in clinical trials. And that's the lenacapavir. This is that first-in-class capsid inhibitor. So new drug, new class, and that's great news. The other thing is it's given as a subcutaneous injection. So unlike rilpivirine, doesn't need to be administered in a clinic or by a healthcare provider intragluteally. It's sub-Q, so potentially could be administered by the patient themselves. And it has a very long half-life that supports every 6-month dosing. So you can think about it as having a potential role in a lot of settings, long-acting therapy for first-line treatment for suppressed patients, and also because it's a new drug and a new class for highly treatment experienced. So the first study is the CAPELLA study. We heard a little bit about it at CROI, and this was the registrational trial, as far as I know, for this drug for highly treatment experienced patients. You don't need a lot of patients in these trials to get this indication because there's such a need. And what they did is they designed this very much like the ibalizumab and fostemsavir studies, where you take highly treatment experienced patients, multi-drug, multi-class resistance, who are viremic, and you basically first look over a short period of time to see if there's intrinsic activity of the drug. So they gave oral lenacapavir a dose of 600 milligrams on day 1 and 2, and then 300 milligrams on day 8 because of the long half-life. And they simply added it to the failing regimen versus the placebo added to the failing regimen. And the primary endpoint was to show a greater than a half a log reduction in viral load between the two groups. And they showed at CROI 88% achieved this goal in lenacapavir, 17% in placebo. So they documented its intrinsic activity, and then they allow people to go on optimized background regimen. And in this particular study, they took the people who originally received the day 8 oral, then they received the subcutaneous injections, 2 1.5 mil injections into the abdomen on day 15 with optimized background regimen. And then they were followed over time versus continuing their stable regimen with the sub-Q lenacapavir. And then what they did is they had this other group that you can see at the bottom were non-randomized. These were people who had a decline of their viral load when they came in, presumably increased adherence between screening and entry. But the primary endpoint I already told you about, this was the 26-week randomized follow-up data in this population. And if you look at the proportion less than 50, it's 81% overall. So smallish numbers, but clearly a very high rate of viral suppression in these highly treatment experienced patients. And if you look to the right, they broke it down based upon the number of fully active drugs in the optimized background regimen. Again, the numbers are small when you start to parse it out like this, but you have, if for people who have one fully active drug in their baseline background regimen with lenacapavir, 86% suppressed. They had 2, 81% suppressed. And what's interesting is that if you looked at people who had no active drugs in their background regimen, the numbers are small, it was only 6, but 4 of the 6, 67% achieved undetectable. So clearly it worked. It was associated with an increase in CD4 of about, on average, 81 cells. And I think, again, really robust. And so the take-home message is overall, very effective part of a new regimen for highly treatment experienced patients, with even the 67% or 2/3 achieving undetectable levels when they had no active drugs in their background regimen. Not our goal when treating people, but I think it speaks to the potency. From a safety perspective, there were some usual common side effects that were described. Again, remember, these people didn't just receive lenacapavir, they received a variety of other drugs as part of their optimized background regimen. So it's impossible to tease out how they may have contributed to some of these side effects. And from an injection site reaction, generally mild, not uncommon, but generally mild and well tolerated. Resistance was an issue. This is a new drug, so it was important to tease out how much resistance there was. And amongst the 36 randomized individuals, there were some people with emergent resistance, and these are the sort of the mutations that have been described with lenacapavir resistance. So 4 with emergent resistance. Interestingly, 3 resuppressed at later visit, and 1 with a change in their optimized background regimen, 2 without, suggesting that not all mutations are the same. And despite the fact that some resistance may emerge, it may not render the drug completely inactive. And those are things that need to be teased out in future trials. Now, another study presented was, and this was presented, I believe, for the first time, is the CALIBRATE study. This is another lenacapavir study, only in this case using it for treatment naive. Because again, this drug has properties that would have value for lots of different populations. Long acting for people without underlying resistance, new drug and new class for people with, and it's also being looked at for pre-exposure prophylaxis because of its long-acting properties. So this was a randomized open-label phase 2 trial. And this is looking at treatment-naive individuals, no active Hep B or C, no Hep B, of course, because as you'll see, some of these regimens don't include Hep B active drugs. And the goal was to, 1, show how active it is, and 2, to perhaps start to think a little bit about some novel maintenance regimens or simplification strategies. So I'll start with group 4. Again, small numbers across the board, but 25 people received basically control, bictegravir, FTC, TAF once a day. And then group 3, or a group of people who received lenacapavir, 50 milligrams orally per day. So they got the lead-in, and then they got the 50 milligrams per day from day 3 after those first 2 doses of 600 milligrams. And they received it with FTC TAF. So a long-acting oral agent, unique drug with FTC TAF, standard 2-nuke regimen. And then there were the more creative arms in group 1 and group 2. Group 1 was lenacapavir every 6 months with FTC TAF for 28 weeks. And that's the data we'll be looking at today. And group 2 was lenacapavir every 6 months with FTC TAF. Again, same kind of regimen. The dosing schedule is very similar to what has been used in the highly treatment experienced population, sort of a load of 600 milligrams day 1 and 2, 300 milligrams day 8, then subcutaneous injection on day 15, and then every 6 months thereafter. So the first 28 days is really looking at these controls, and lenacapavir is an oral and a short-acting. Then the creative part, which we don't have the data on yet, is that if they get virologically suppressed at week 16 and 22, then they go on these maintenance regimens of lenacapavir every 6 months with either TAF, so just 1 nuke, or bictegravir, just an INSTI. So here's the 28-week data. So again, this is before the clever switch to maintenance strategies. And you can see small numbers, but very high rates of virologic suppression, with very few people experiencing viral loads of greater than 50 copies per mil by week 28. So it looks like a viable strategy, either orally or subcutaneously with 2 nukes. And then, of course, we'll learn more in the future. The other reminder was there was 1 participant who had emergent resistance at week 10. So resistant mutations are real. Obviously, the barrier to resistance for this drug is not what we see with second-generation integrase and boosted PIs, but is certainly high enough and potent enough to achieve high levels of suppression. From an adverse events perspective, generally well tolerated. The injection site reactions, again, occurred in a large proportion of people, about 40%, but the overwhelming majority were grade 1. Generally resolved over the course of a few days. And this figure shows how these different side effects, swelling, erythema, pain, came on and then tended to go away over a few days. And the subset of people who received their second dose at 6 months, similar kind of side effects, suggesting maybe a little less common, but I think the data set's really too small to be able to know just yet what we might expect. So, Shobha, let me ask you a couple of questions as we talk a little bit about this. And, how many people do you see with these highly treatment experienced type patients and that you think you might use this as part of a regimen?
So I think if you had asked me that question maybe a year and a half ago, I would have said, or 2 years ago in our practice, I would say, this is small, particularly those who've been diagnosed, years ago, got switched on integrase early on, and then, accumulated resistant mutations. What I have started seeing more recently, and, COVID, I hate to bring it back to COVID, but in the past year and a half, the monitoring in-person visits have been less frequent. The viral load monitoring has been less frequent. So I'm starting to see, patients kind of fail the second line integrase inhibitors. So, and then, with pre-existing NNRTI mutation. So I fear that, and that scenario may be present not just here, but, and it might evolve over time because, they were so great for so long, but with COVID and associated challenges with mental health, there have been issues with adherence with many of my patients. So I'm starting to see, a little bit more. But the key really is going to be, I guess, trying to figure out the partner drug. Because on paper, it sounds great, to be able to really offer DOT, right? Because if you're going to give a sub-Q injection, every couple of months, I'd like to not have to take a pill daily at the same time. It defeats the purpose of having to take the sub-Q injection. So hopefully, if we can find a good enough partner drug where you eliminate the need for oral therapy, because I think what's great about lenacapavir is they have studied it. Typically, we see it in just one, either approved for treatment-naive, no virologic failure, or heavily treatment-experienced. We rarely have something that's actually can help both patient populations, which is a more realistic way when you see those patients. I'm excited to see that aspect of the data, but I think finding a good partner drug. I know that the companies are looking at co-developing potentially, either islatravir with lenacapavir and for less frequent dosing. I think so that might be something exciting for us to look into and see that would be an option. So I'm excited that we have a new drug, a capsid inhibitor, a novel class. Hopefully there shouldn't be a cross-class mutation. So they should still remain active. And the fact that even with single drug, even though the numbers were small, that it was so effective with not just viral suppression, but also improvement in the increase in CD4 count. So that's kind of exciting.
Yeah, I agree. I mean, I think it's wonderful to see them starting to tease out whether you can use it as some of these novel 2-drug type regimens. But I agree. I think for it to really get a lot of traction and to be a lot of value added for our patients, we're going to really need to come up with something long acting to go with it. And wouldn't it be great if we could come up with another 6-month drug? That may be a lot to ask for, but there are certainly drugs being looked at that have long half-lives, but even something once a month maybe would have advantages for our patients over what they're currently doing, or this intramuscular injection that's needed with cabotegravir. So I think it's great it's moving forward. For highly treatment experienced patients, I think for those who need the drug, there are not that many of them, it's great. I do think we have, rare patients in our clinic that we've successfully treated with ibalizumab. We don't have any data, but maybe a switch option would be available for them so they don't need to come in for these infusions every couple of weeks. I can think of a lot of places for that highly treatment experienced subset of patients where it might fit in. For the others, we probably need a good partner. I agree. And the resistance issue, I think, is a real issue. Clearly, it's going to come up. So we do need to be careful how we use this drug. We can't think of it as something we can use with as part of a regimen unless it's really supported by the background.
Right, particularly given that it's going to be long acting. And, so theoretically monitoring might not be as frequent. So we want to make sure that we really, in care, follow them closely. So but it can't come time for injection, they are getting the second injection or the third or whatever, within appropriate time points, and checking for viral load, because that's what can potentially drive development of resistance.
Yeah, that whole tail issue. Talk about a long tail, huh? The drug with this half-life. Well, let's move on to, you already sort of introduced islatravir as another potential drug in development. Islatravir is this nucleoside reverse transcriptase translocation inhibitor that has these properties of being active at a very small dose, so very potent, and active against most viruses that have broad resistance to nucleosides. So again, a possible option for people who are highly treatment experienced who need a new drug. A possible option is something more long acting. And then potentially used as sort of novel combination therapies. It's also being looked at as a novel strategy for prevention. So a lot of potential roles. This protocol 011 we've seen before. This is the 96-week safety data. This is a very early, relatively small study that took people who are treatment naive with no antiretroviral drug resistance, no active Hep B and C, again, some issues about using regimens, novel regimens without tenofovir. You don't want people with Hep B. And they randomized people to either a regimen of doravirine 3-TC TDF plus placebo once a day, or one of 3 doses of islatravir, 0.25, 0.75, and 2.25. So again, really tiny doses with doravirine and 3-TC. And those who achieve virologic suppression at 20 weeks, and we've seen in previous data sets that this occurred in a large proportion, they then got switched to that islatravir dose with doravirine alone. So a maintenance regimen with just 2 drugs and no other nukes, and obviously no other drugs in other classes other than the islatravir and doravirine, the NNRTI. And then 96 weeks, they gave them optimized islatravir dose based on the data that emerged from this and other trials, and went with 0.75 milligrams with doravirine. So a pretty simple regimen with a total drug mass of 1.75 milligrams, 100.75 milligrams. So really low drug mass, and then followed them up. So this is the safety data that came out of this trial. And it's looking at cumulative adverse events across the different dosing arms at 0 to 96 weeks. And you can see overall greater than or equal 1 adverse event, including the control arm, was common, as we see in all of our trials. If you looked at drug-related adverse events, again, the numbers are small, but it occurred across all of the groups, except there were none in the very low dose of islatravir. It's hard to know how much of this is real versus a product of just small sample size. Serious adverse events were uncommon in the islatravir arms, and then the number of people who discontinued because of adverse events, 0 in the 2 lower doses of islatravir. There were no new drug-related adverse events or discontinuations between 48 and 96 weeks. And the most common side effects that were described were headache. And then in the doravirine 3-TC TDF, a little bit more in the way of diarrhea. So generally well tolerated, clearly effective in a small number of people, including as a novel 2-drug regimen. Here's some laboratory data looking at fasting triglycerides of over 500, again, relatively uncommon. Alanine aminotransferase elevations, uncommon, and CPK elevations. So there were no dose-related trends, no common laboratory changes that were really teased out in this. And the elevated CKs were mostly associated with physical exertion, which we see with some frequency. So, this leaves us, Shobha, to thinking about what our potential role might be for islatravir as we think about it in all these different settings and based on the data available. And also, again, coming back to this, the value added of a novel combination 2-drug regimen like islatravir doravirine in a world where up until now, most of our therapies have been integrase-based. What do you think?
So I think it's a moving target. What is becoming increasingly clear is you don't really need a 3-drug regimen all the time if you have the appropriate patient population. I think that seems to be particularly in naive patients without Hep B or Hep C, and that's the biggest thing. We really can't forget about those, particularly Hep B and C. You don't want to inadvertently give these 2 drugs a regimen because they were excluded. In those patients, it's certainly, I think we have enough 2-drug combos that have shown to be safe and effective, provided you select the right population. What's interesting for islatravir, I think, is because of its long, again, as we talked about, its long durability, long PK, it really makes for much less frequent dosing and, gives you the opportunity to, formulate when you come to implementation, right? Like a directly observed therapy sort for persons living with HIV infection. It could be done at many different, and when you start thinking outside the box, not all healthcare needs to occur in the physician's office. So, and these are things that we have to start thinking about. There are other places in the community and going out there where you could really implement this quite well, provided this combination pans out. This is still pretty early, so I'd like to see more durability of the virologic data, going out to 144 weeks. and looking at failure, because as an ID physician, you're always thinking about, well, if this fails, what's your plan B? And then what is your plan C looking like? What are the resistance mutations going to look like? I think it's great that our patients will hopefully have, additional treatment options, provided the safety and efficacy does pan out with a long-term follow-up on these studies.
I completely agree. I think it's great to see new drugs being developed, especially that have potential roles in naive, for maintenance therapy, for treatment experienced people, and even for PrEP. So it's great to see this kind of data emerging and learning more about the safety. And, the issue of doravirine, in an integrase-based world is, may change as we learn more and more about the potential contribution of these integrase inhibitors to weight gain. I don't think we have it figured out yet. And we have studies going on that are looking at switch strategies to NNRTIs like doravirine to see if that's associated with weight loss. We don't have that data yet, but it might, the role of these novel combinations may evolve, just as everything in HIV treatment as we learn more. So let me move on to the next slide with islatravir also. In this case, it's looking at it in the context of pre-exposure prophylaxis. This is protocol 016. And we'd seen some earlier data at CROI looking at the PK of an implant impregnated with islatravir, one novel way of providing drug for prevention. This is taking advantage of the long oral half-life as well. And here they gave oral islatravir once monthly. And this is the week 24 safety and PK data. And you can look at the doses. There was a placebo arm, but they had 120 and a 60 milligram dose every month. If you remember the dose they moved forward with in that phase 2B trial, it was 0.75. So again, the drug is so well tolerated that they can increase the dose by 60, 100 plus fold orally and have good tolerability and markedly extend the levels. So here they're thinking about in the context of PrEP. And so they were really looking at the safety and the PK. And this is looking at adverse events, and adverse events are not uncommon, but drug-related adverse events generally were uncommon, 10%, 15%, even more in the placebo group. And serious adverse events were very, very rare. So it looks like people will tolerate these higher doses of 60 and 120 milligrams. What about the levels? Oh, here's the additional laboratory data. And you can see the most common side effect associated with these higher doses of once a month drug were things like headache, mostly grade 1, a little bit of diarrhea, but that was no different than placebo. Similarly, the nausea, maybe a little bit more frequent, but again, doesn't look much different than placebo. So headache seems to be the thing that might stand out a little bit, but all grade 1. And this is the punchline, I think, is the PK data, looking at the 24-week islatravir levels in PBMCs, the 60 milligram in the top panel, 120 milligrams in the lower panel, and they had this PK threshold of 0.05 picomoles per million PBMCs as the level they think would be important from a prevention perspective. And if you look at week 4 and week 8 after the last dose, so this is actually looking at what's left 8 weeks after they received their last dose, because they were taking it monthly up until then. And you can see that they maintained levels with both of the 2 doses that were well above the threshold that was needed, even after an 8-week interval from the dose, suggesting perhaps that the dosing frequency might even be extended further than monthly. So I think that's the punchline. It's well tolerated at the high dose, and even at 8 weeks, they maintained these sufficient levels, we believe, for preventing infection. Obviously, we need the clinical trial data to prove it prevents it. And then we're going to close with a study that is a little bit unrelated to HIV, but it's in an important population, and I think is a substantial advance. This is, I think it's called the Xenix trial, and it's looking at 3 drugs that are cidal against mycobacteria in treatment of highly resistant tuberculosis. And there was a NICS trial that was published about a year ago in the New England Journal of Medicine that also looked at this BPaL regimen. And what was interesting about it is it showed that it was highly effective, but there were some significant tolerability issues, as might have been predicted with linezolid. and that over 80% developed some level of peripheral neuropathy and about half developed some cytopenias. So what this study was doing was it was a phase 3 trial to, one, look at how effective it was, but also to look at perhaps some different doses of linezolid. Looking at, in the top group, BPaL with linezolid 1,200 a day for 6 months versus linezolid at 1,200 a day for 2 months versus the lower dose of 600 a day. It's for 6 and for 2 months. And the primary endpoint was bacteriologic failure, relapse, or clinical failure through 6 months after the endpoint. So this is the efficacy data. Favorable outcome across the 4 different study arms was in the 85 to 95% range. Again, relatively small numbers, but pretty amazing response rates. And if you look at the number of people who withdrew for adverse events, it remained relatively low. So they had favorable results using BPaL, similar to what was seen in the NICS-TB study. All outcomes had culture negative status at 6 months, and the time to negative status in all treatment arms was shorter. So again, a very effective potential option for people with potentially some learning a little bit more about ways we can make it easier to tolerate, such as shorter courses of linezolid, such as 2 months, with either the higher dose or potentially the lower dose. So a really important trial for people who are managing these patients. From a safety perspective, looking at any serious treatment-associated adverse events, relatively limited. The peripheral neuropathy, if you look across the arms, again, you get a sense that it was lower in the people who received the lower dose and for the people who received it for only 2 months, even though the overall efficacy looked very good across the board. And if you look at the bottom, dose modification of linezolid for any one of a number of reasons, again, you get a sense that the lower dose was tolerated better than the higher dose, and every 2 months had advantages over every 6 months, even with that higher dose.
Wonderful. Thank you very much to Drs. Daar and Swaminathan, and thanks to our listeners for joining in. As a reminder, to view the full educational program, Contemporary Management of HIV 2021, on the Clinical Care Options website, please click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.